Hello students, I am Dr. Saurabh Srivastava, reader in the Department of Oral Medicine and Radiology, PPT College of Dental Sciences, Lucknow. So, we'll be continuing with the topic of antibiotics and dentistry with the second part involving the various medicines we are using in dentistry, their mechanism of actions, what are the indications, what are the interactions, and all the things regarding the antibiotics which are used in various odontogenic and non-odontogenic infections. So the antibiotics which are used in dentistry, they can be working on the basis of the principles of inhibition of protein synthesis, inhibition of the cell wall synthesis, interference with the cell membrane structure, interference with the nucleic acid synthesis, or they can be topical antiseptics and antibiotics which will work in the similar manner. So we should remember about the protein synthesis, cell wall synthesis, cell membrane structure, and the nucleic acid synthesis. These things will be involved with various antibiotics which are used in for the microorganisms causing the odontogenic or the non-odontogenic infections. Now we come to the inhibition of protein synthesis. What all these antibiotics are involved in this, or which work by inhibiting the protein synthesis? The first is tetracyclines, second group is the macrolides, and the third is aminoglycosides. You must be knowing all these groups, we have studied them. We will be just briefing about these. Now tetracyclines, they inhibit the protein synthesis by binding to the 30S ribosomes in the susceptible organisms. Now it is given mainly orally and is secreted in the saliva, concentrated in the liver and excreted in bile. They also cross the placental barrier and used as an adjunct to the conventional periodontal therapy for the treatment of enug and various dental abscesses related to the periodontium. So what dosage has been decided as adult dose for tetracycline? It is 250 or 500 mg QID. Orally, minocycline, it is a congener of tetracycline which is given orally in dose of 200 mg BID or OD. And doxycycline, again the capsule doxycycline which is commonly given, it is given orally 100 mg BID for the first day and subsequently daily dose OD dose of 100 mg. So the 100 mg BID dose was the loading dose on the first day, which we had discussed earlier. It is active against the gram-negative and the gram-positive bacteria, tetracyclines, Rickettsia, spirochetes, protozoa, and the mycoplasma. So tetracyclines are the broad spectrum antibiotics, as we say. They work on a variety of microorganisms. They reduce the protein synthesis and usually have an overall catabolic effect in the body of the host. So they induce a negative nitrogen balance, means they are reducing protein synthesis in the body of the host also. They increase the blood urea level also. All the tetracyclines have been contraindicated during pregnancy. As they cross the placental barrier, which we have discussed in the previous slide, they form a stable calcium chelate or the complex in the bone forming tissue and in the teeth also, which can result in a decrease in the growth rate of the bones and retardation of the skeletal development. Also with these, there is discoloration of the teeth by these chelates which are formed in the calcium content of the teeth. So the drug should not be given even to the nursing mothers as it is excreted in the milk. So it is contraindicated during pregnancy. It is not to be used in the third trimester. Contraindicated. What all things does it interact with? It interacts with oral contraceptives, antacids, penicillins, anticoagulant therapy, Then we come to the macrolides. It is another group of drugs which is causing the bacteriostatic effect. As it interferes with the protein synthesis by inhibiting the enzyme transferase at the 50S ribosome unit. So in tetracyclines it was the 30S unit subunit, and here macrolides, they act on the 50S subunit of the ribosome. They are also effective against gram-positive and gram-negative bacteria, and depending on the concentration of the drug, it can be bacteriostatic or bactericidal. It depends on the concentration. So it is effective against the penicillin-resistant staphylococcus infection. This it is used in tetanus, diphtheria, syphilis commonly, and in the cases where the oral infections are involved, macrolides are not the first choice. They can be given as an alternative drug, and the excretion of these drugs is through the urine, feces, and bile, and it is partially destroyed in the gastric juice. So it has to be administered as an enteric coated tablets. And azithromycin is a more effective drug which is used as an alternative antibiotic against the odontogenic infections and the periodontal abscesses. So in erythromycin, we used to give 250 to 500 mg of the drug 8 hourly. Azithromycin and spiromycin have also been used as alternative drugs, and erythromycin has been utilized as an alternative drug for prophylaxis against the infective endocarditis in patients who are allergic to penicillins. Now we come to aminoglycosides. It is the another group of drugs which has bactericidal effect due to their ability to cause detachment of the ribosomal complex from the mRNA. They detach the complex itself from the mRNA, which would result in inability of the cell to produce the essential proteins. And due to the synergistic effect of this drug with other antibiotics, they are usually given in lower doses and in combination with other drugs. Commonly used aminoglycoside is the gentamicin, which is given as intramuscular or slow intravenous injection, 2 to 5 mg per kg per day in 3 divided doses. It can produce the bactericidal effect in this dose. Then tobramycin, streptomycin have been given for acute infections, and these drugs are more toxic than other categories of drugs, other groups of drugs. So they have to be given in very severe infections when other drugs are not effective. These are ototoxic, and they are given for gram-negative bacillar infections, and usually in combination therapy where their doses can be reduced. So they should be utilized as this. Then to come to other class of drugs which inhibit the cell wall synthesis. Namely, we have certain drugs like penicillins, cloxacillin, ampicillin, amoxicillin, cephalosporins. All these drugs, they will inhibit the cell wall synthesis itself. And these are common drugs which are utilized in odontogenic infections. So we start with the penicillin then. They are an antibiotic called as the beta-lactams, which have a bactericidal activity against broad spectrum of the bacteria. Now the most important antibiotic, it was extracted from a mold or fungus, Penicillium notatum, and then Penicillium chrysogenum was found to give more penicillin. So it is employed now for commercial preparations, and they are considered to have an effect of over a broad spectrum of the bacteria. Now with the advent of penicillin and its effect on the bacteria also got resistance against the various aspects where the penicillins usually had their effect. So penicillinase resistant penicillins have been developed, penicillins which are effective against gram-positive and gram-negative organisms have been developed, and penicillins with beta-lactamase inhibitors have been developed in the due process. So these were the demand or the demand of the times when the mutations have changed the drug. We come to cloxacillin. It is used in conjunction with ampicillin or amoxicillin to enhance the synergism. This is a penicillinase resistant penicillin, and the drug has weaker antibacterial activity than the penicillin G. So it is used in conjunction with ampicillin or amoxicillin to enhance the synergism. Over here, the food interferes with the absorption of the drug in cloxacillin also. So, a high concentration will occur in kidney and liver, and about 90 to 95% is bound to the plasma proteins. And the dosage which is required for the penicillins, an initial dose may vary from 0.5 to 1 gram given QID, with a maintenance dose of 250 mg QID. The drug should be administered 1 hour before or 2 hours after meals, as we have discussed before, to ensure the adequate absorption of the drug and prevent the interactions. Ampicillin. It is an effective drug against gram-positive and gram-negative organisms. It is inactivated by penicillinase. So, it is antibacterial activity of this drug is similar to benzyl penicillin, and the gram-positive cocci are less sensitive to ampicillin, and ampicillin is absorbed completely on oral administration, and food does not interfere with its absorption. So it is the plasma levels are reached at peak within 2 hours of its oral administration, and 1 hour after oral and the intramuscular administration respectively. Means after intramuscular 1 hour and on oral 2 hours. After that the peak levels will be reached. The dosage which is given for this drug, it will be about 250 to 500 mg QID, as large as 1 gram QID may be required for more refractory gram-negative infections, means infections which are not responding to the dosage, which are less than 1 gram. Then we can go up to 1 gram, and high dosage of intramuscular intravenous injections are used in the treatment of meningitis and bacterial endocarditis. Now, to say that diarrhea is a common adverse drug reaction or side effect for the ampicillin or various penicillins which are given orally, ampicillin will cause skin rash and is usually maculopapular skin rash as an adverse drug reaction. Coming to amoxicillin, it is more effective against gram-positive and gram-negative organisms than ampicillin. It is a semi-synthetic penicillin, and it has substantial advantages over ampicillin. It is effective on oral administration, as ampicillin was incompletely absorbed. This is absorbed more than ampicillin, and blood levels are twice as high than with the similar doses of ampicillin. So absorption is not affected by food in this case, and the blood levels, as we say that we will reach the blood levels which are required more in amoxicillin than ampicillin, and the incidence of the skin rashes is also lesser. Even diarrhea is also lesser in ampicillin. Now, the dosage which are given with amoxicillin are 250 to 500 mg TID, and IV and IM dosage can be also given. Now, the adverse drugs reactions of penicillins, they may be least toxic, and hypersensitivity has been found to be the most common adverse drug reaction noted with any penicillin. Then maculopapular rashes, urticaria, fever, bronchospasm, vasculitis, all these, and last but not the least, anaphylaxis can also occur with the use of penicillins. But whenever injection penicillins were given, they were more common with injectable varieties, not with the oral ones. Then the broad spectrum penicillins, they alter the natural bacterial flora of the oral cavity as well as the GIT. They result in superinfection with the resistant bacteria, colonization by opportunistic pathogens and fungal infections, or maybe causing pseudomembranous colitis also. Now, the interaction of this drug with others can be seen with aminoglycosides, so they are not advised to be given together. Then we come to cephalosporins. Cephalosporins a wide range, are having a wide range of activity against gram-positive and gram-negative bacteria, and they act by inhibiting the cell wall synthesis and also are bactericidal. So they can be either given orally or intravenously, and they are eliminated by renal excretion primarily, and the allergic reactions like the skin rashes, fever, serum sickness, they are usually lesser with cephalosporins. But some of the newer cephalosporins, they can cause disulfiram like reaction when combined with alcohol. So we'll be very careful when giving cephalosporins to patients who consume alcohol. So in such cases, a disulfiram like reaction will occur, and various generations of cephalosporins have been seen as their development of from first to the fifth generation, depending upon their spectrum of activity on various types of bacteria. Now, some cephalosporins to name are cefalexin, cefaclor, cefixime, all which can be used in our odontogenic infections. Then the drugs or the drug groups which can be used based on their interference with the cell membrane structure. If the drug is acting on the membrane of the cell, it will certainly destroy the cell by breaking the membrane and causing the contents of the cell to move out. So these drugs are polymyxins, which are antibacterial, and polyenes, which are primarily antifungal. So like amphotericin B and nystatin, these are all acting on the cell membrane structure. Over here, we can say that the selective permeability of the cell membrane to control the entry and exit of the substances uh, by specific transport mechanisms is there, and the membrane is also associated with certain vital functions such as the DNA replication and the cell wall synthesis. So if this membrane is attacked by any drug, it will disrupt or hamper all these functions of the cell membrane, and any drug will be lethal for the cell if it happens like this. But there is also an unfortunate part with these drugs that they are not target specific. They do not exhibit selective toxicity. So they are equally destructive to the microorganism, its cell, as well as the cells of the host or the mammalian cells. So whenever we are giving drugs which are having their effect on the cell membrane, we have to expect more and more toxic effects of the drugs to the host tissue also. So polyenes, which we say have more effect on the fungi or the fungal diseases, they bind to the sterols of the plasma membrane of the microorganism and result in the alteration of the membrane permeability. They are very toxic and have numerous side effects because these polyenes, if they are binding to the sterols of the plasma membrane or the cell membrane, even the human cells or the mammalian cells, they have cholesterol component in the cell membrane. So it will bind to the cholesterols also and will cause permeability or the leakage of the essential metabolic products from the cell in the host cell also. So we can say that host toxicity is there with the polyenes and polymyxins, which are polymyxin B and E, are used only in cases of gram-negative bacteria which are resistant to multiple antibiotics. In case of amphotericin B, primarily we can use as topical application, lozenges, or any locally applied medicine before going for the systemic treatment, because we estimate that the systemic treatment will give us more and more toxic effects. Now, and amphotericin B is available as a lotion, as a cream, ointment for cutaneous candidal infections, and lozenges for the treatment of oral candidiasis. Similarly, nystatin paint is available, and lozenges can also be given for local application against the candidal infections. Now, drugs which interfere with the nucleic acid synthesis. These are nitroimidazoles and quinolones. Now, several antimicrobial agents, they inhibit DNA or RNA synthesis, and most of them do not exhibit selective toxicity. However, nitroimidazoles and quinolones, they do exhibit selective toxicity and are clinically useful. Therefore, in the treatment of certain bacterial infections, they have lesser side effects to the host. Now, nitroimidazoles, the evidence shows that they interact with the bacterial DNA, and reports of carcinogenicity of this drug has also been seen in rodents, but it may be related to the liver microsomes, which can reduce the metronidazole. So the concurrent administration of metronidazole and amoxicillin or augmentin, it has been used with success in the treatment of both periodontal diseases in children or in various types of periodontal infections where actinomycetum comitans is also associated. So in dentistry, we give it for the treatment of obligate anaerobes, which are used in or which cause infections of periodontal disease or the periodontium in the sulcular depth, which remain in the sulcular depth, and mostly the anaerobic infections are there in that area. We use the nitroimidazoles, which can be metronidazole, tinidazole, secnidazole, ornidazoles. So they have been used for the periodontal diseases with success. It can be rapidly and almost completely absorbed from the small intestine, and very little will reach the colon, and food does not affect its bioavailability. But the drug is metabolized mainly in the liver, and it is excreted mainly in the urine, imparting a very deep reddish brown color to the urine. It also crosses the placental barrier and is present in the milk in the lactating mothers. So there is a metallic taste also in the mouth whenever the patient is taking metronidazole, especially the metronidazole. And a concurrent consumption of alcohol with metronidazole will cause disulfiram-like reaction or antabuse reaction due to accumulation of acetaldehyde in the blood. So we have to again be very careful. Just like in the case of cephalosporins, disulfiram reaction can be seen with metronidazole, very common. Now the dosage of metronidazole can be 200 to 400 mg TID given. IV it may be 500 mg. And the tinidazole, secnidazole and ornidazole have got longer half-lives with a dose of 500 mg BID for the periodontal infections. And coming to the quinolones, these are synthetically produced drugs, and therefore they are not true antibiotics. In this category, we have ciprofloxacin, norfloxacin, ufloxacin, defloxacin, amifloxacin, levofloxacin, catifloxacin. They inhibit the bacterial DNA replication, and by interfering with the gyrase enzyme. So the DNA is not possible to arrange itself. It is not possible for the DNA to arrange itself in the structure which is required for the pathogenicity. So these are not true antibiotics. Acid and nalidixic acid and ciprofloxacin, they are considered bactericidal. Then we come to ciprofloxacin, talking more about the drug. They are useful in the management of mixed infections where Pseudomonas infections are there, gram-negative organisms are there, and gram-positive ones are also there. The newer quinolones may not be used routinely by the dental professionals due to the resistance which is encountered with the oral flora. And ciprofloxacin is excreted in the breast milk and across the blood placental barrier. So it should not be given to the pregnant women or the nursing mothers except in cases of severe infections. They are not recommended for prepubertal children also. Now quinolones, they inhibit the metabolism of theophylline and caffeine. Usually antacids uh, and zinc containing multivitamins or iron containing preparations may substantially interfere with the absorption of ciprofloxacin. So ciprofloxacin has a certain amount of interaction with various drugs which are commonly taken like multivitamins, antacids, iron preparations. And the dosage of ciprofloxacin can be 250 to 500 mg BID orally, and intravenously they are also given. Ofloxacin and sparfloxacin can also be utilized for various oral and dental infections. Now coming to the topical antiseptics and antibiotics. Whatever effect we assume or predict from systemic intake of the antibiotics, if we can get it from topical application, or the effect which we need by applying on the skin or the mucosa, we can surely get much more effect if the pathogens are more on the surface than into the system. So in the periodontal diseases, the subgingival species of bacteria, they are reduced or eradicated with the use of the topical application of these antibiotics. Then local antimicrobial therapy. Now systemic therapy is the common therapy which is given for the infection which is present in the body. But if we know that in a periodontal tissue infection is present at that site only, so in that case risk of adverse effects is more if we give it systemically. If we want to give it as a local therapy, we can give into the sulcus itself and leave it for there. So the local antimicrobial therapy has been classified as home oral hygiene regime and professionally applied regime, which can be, both of these can be non-sustained type or the sustained type of subgingival drug delivery systems. So the home self-care or personally applied regime of drugs which has non-sustained subgingival drug delivery. It may include the oral irrigation by the person itself, and the sustained type which will have the subgingival drug delivery system. Actually, no such system has been developed which is very much sustained into the sulcus or which has too much prolonged effect. Then professionally applied or the dental office type of local antimicrobial therapy, where non-sustained type of the drug delivery system is the pocket irrigation by the professional, and the sustained type will be the controlled release device which can be applied by the dentist or put by the dentist into the pocket. The patient cannot do it. So in this we can utilize or drugs which have been utilized as antimicrobial agents are chlorhexidine. They have been povidone iodines and the various chloramines, amine fluorine gels. So these have been utilized for the various personal and professional therapies. Now the dose calculations. The calculation of dose in children is required where Young's formula and Clark's formula, as you all must be knowing, has been utilized for determining the dosage. Then the prophylactic antibiotics which we utilize before, we had discussed previously prophylactic antibiotics for infective endocarditis and prophylactic antibiotics for any infection post-operatively in the wounds. So we have been giving amoxicillin, ampicillin, clindamycin, cefalexin or cefadroxil, azithromycin or clarithromycin as the drugs of choice and the alternative drugs. So in the use of antibiotics, we have to be precautionary in cases where the patient is having pregnancy, in the cases where the patient is having kidney failures, in the patient having liver failures. So in cases where pregnancy is there, most of the times no antibiotic is there which will not have any effect on the fetus. So sometimes we have to give certain antibiotics, and those antibiotics which are given, they can be given based on the assumption that it has antibiotics which have not been or which have not shown any human or animal effects, and these have not been evaluated with much more efficiency. But most of the antibiotics are not to be given in cases of pregnancy, but beta-lactam antibiotics are sometimes given cautiously. In cases of kidney failure, most of the drugs which are eliminated to the kidneys, they cannot be given as such. They have to be either modified with their dosage or have to be stopped. Similarly, in case of liver failures, most of the drugs which are metabolized in the liver and which are eliminated in the bile, in patients of liver failure, they should be restricted or avoided to avoid the toxicity, and which is secondary to the overdosage of these drugs. So to sum up this part of the antibiotics use in dentistry, we can say that various drugs which have been used have been classified according to the area or the spectrum where the drugs are acting upon, either the cell membrane, the cell wall, either the protein synthesis. So we have taken into account the various beta-lactam antibiotics, various macrolides, aminoglycosides, tetracyclines. We have seen the quinolones. We have seen the nitroimidazoles. We have seen the effects of polymyxins, polyenes being most toxic. We have seen that what prophylactic antibiotics can be given. We have seen the various precautions which have to be observed with the use of antibiotics, and I think the dosage and efficiency have to be judged clinically, and the patient customization of the antibiotic regime has to be done, which will depend on your clinical efficiency of the disease process. If the pathophysiology of the disease is known to the clinician, then it is very easy to determine the microorganism effect of which antibiotic is there on the microorganism. And nowadays empirical therapy as well as the selective therapy or the very specific therapy can be given. Most of the times we know what microorganisms are affecting or are causing that disease. We give empirical therapy based on that. But if the specific therapy is given, it is much more beneficial to the patient as it will have more effects rather than the side effects or the adverse effects. So to come to a specific therapy, we have to get or take into account the culture and sensitivity tests, which will tell us which antibiotics are more effective to the flora or the microflora which is causing the disease process. So all the queries will be entertained on my email ID, and thank you so much.